Yeah.
Dr. Long, when did you start making progress on being one of the top orthopedic surgeons in America and perhaps the world?
The biggest thing that's changed and the thing that's made the biggest improvement in hip replacement is the use of computers in the operating room. If you can imagine now, it's possible to put a tracker in the pelvis and another tracker in the thigh, and you can have an image of that person's hip while you're operating. You can see the shape, you can see the angle of the implants, you can watch the implant go into the bone, you can measure limb lengths. And 10 years ago, we began research on that type of technology, and now we use it on every operation.
Can you explain about how many hip and knee replacement surgeries have you completed up until now?
Yes. Every year, I perform between 300 and 400 hip and knee replacement operations. The thing that I do that's different than most surgeons is 100 of those operations are surgeries in people that had an operation before and the operation failed. If the ball comes out of the socket, if someone has a hip replacement and they fall and break their bone around the hip replacement, if the parts wear out, if the leg was put in too long or too short, or if the parts are put in wrong, I'm one of the few surgeons in the U.S. that will go back in and repair it.
Okay. And how much has computer-assisted surgery revolutionized what you do?
Well, just imagine the top 3 problems in the United States and around the world for hip replacement don't occur if you have a computer. The number 1 reason orthopedic surgeons in the U.S. get sued is because the patient comes out of the operating room and the legs aren't the same length. With computer navigation while we're operating, we can watch 1 millimeter changes in the length. 1 millimeter increment changes are visible to everyone in the room, so we never finish the operation and find out the leg's too long. We know while we're doing it. So that's just one advantage of navigation. The second thing is the biggest cause of needing to go back to surgery besides limb length is the ball coming out of socket. In the US, 5%, almost 5% come out of socket. But if you have a perfect shape and the socket in the perfect position and the ball is in the perfect position, they stay together. If you have one of them turn one direction and the other turn the other, they'll come apart. So you have to have perfect alignment of both parts. With navigation, you can have it every single time. If you don't have computers, you put the parts in, you close the patient, and get an x-ray, and you hope the parts are in the right place. That's the difference.
Dr. Long, why isn't everyone else doing this? Why aren't the other doctors in your field doing this procedure?
The best way to understand is think about pilots. There was a recent plane crash in San Francisco, and pilots have 2 ways to land a plane. One is they have a screen, and while they're landing, they can see the wings, an image of the wings of their plane, and they can tell if it's at the right level, if it's too low, too high, too fast, too slow, while they land the plane. The other way is you just use your eyes and you land the plane. And you have pilots doing it both ways now. Hip replacement and knee replacement surgery, you can do it with computer or without. 10 years ago, they were very slow. They were rare. No hospitals had them. The surgeons don't purchase them. The hospital has to buy it. So 10 years ago, the surgeons would have to beg the hospital to buy this expensive technology, and it cost $500,000 about a decade ago. Now it costs less, it's faster, it's quicker, but many surgeons never learned how to use it, so they're still not using it. There's no more argument whether or not it's better to have those computers in the room when you do the surgery. The only argument is whether or not you've taken the time to learn to use them.
Okay. Now some questions about the surgery itself. How long does the typical hip replacement surgery last?
Today's hip replacements will last the patient's lifetime. All of the hips before this generation had a limited lifetime, and they would say maybe 10 years, and it'll wear out and you'll need another hip. 15 years was supposed to be a good result, but we have materials now that don't wear out.
How long does a typical computer-assisted surgery last as compared to the general way? that is being done?
So the timing of surgery, it really depends on the team that does your operation. In our room, it's about 1 hour. The operation from the time we make the incision till the time that all the parts are inside the body is about an hour and 15 minutes to close the incision. That includes setting up the computer, putting trackers in the patient that will track any movement of the pelvis, opening, putting all the parts in, and closing.
How much time would a usual without the computer-assisted surgery? How long does it usually take?
Well, our room is different. One of the reasons that surgeons don't use navigation is because it takes longer in some surgeons or some operating rooms' hands. It could add even 30 minutes to the operation. In our room, the people that take care of the computer, that take care of the patients, they've been together 10 years or 15, so all of them do the computer all the time. So in our room, it adds about 10 minutes to the operation.
Okay, and a big question the Japanese audience likes to know is, how large is the incision as compared to standard means?
13 years ago, we did a hip replacement through a 13-inch incision. This year, it's about 3 inches, 7 centimeters, could be typical operation, 7 to 10 centimeters.
And how safe is your type of surgery as compared to standard methods of surgery?
There are 3 risks of surgery, 3 big categories. Number 1, by far, is the anesthesia. The anesthesia carries most of the risk of the operation because if you are not breathing and there's a tube in your throat and you're on a respirator, that's a dangerous situation. What we do is we do regional blocks where if we're operating on the knee, we put the legs to sleep. We don't put the patient's brain so that they're unconscious. We allow the patient to sleep, but they're breathing on their own with an oxygen mask. Most operating rooms use a general anesthetic where there's a tube in the throat. So they give an intravenous medication, the patient goes completely unconscious. They put a tube in the throat and breathe for you. That's general anesthesia. In our room, we use epidural, or we'll just block the limb, and then we give a sedative so the patient sleeps, but they breathe room air and oxygen through a mask on their own, so they don't have to hear the operation or see what we're doing. That cuts down the risk of anesthesia. Also, if you're not breathing in the anesthetic gas, it doesn't soak into your tissues and then cause confusion, memory loss, make you sick after the operation. If we use intravenous sedative, as soon as we shut it off, you can wake up and you can walk.
Okay, how is pain managed after surgery?
Yes. In knee replacement, the thing that we do with anesthesia continues on the floor when you leave the operating room. So for knee replacements, we place a catheter next to a nerve in the thigh, and there's a drip. That drip makes the nerve go numb, and you won't feel any pain in the surgical site. The old way of controlling pain was to give morphine by shots in the arm or in the IV. That will take the pain away, but you'll get so sick and so dizzy that you can't walk, you can't get up after the operation. So we control pain now with pills and nerve blocks. We do anesthesia with nerve blocks, and that's how we make the surgery less dangerous.
Okay, statistically, how successful are your procedures as compared to conventional operations that don't use computer-assisted surgery?
Yes. The biggest statistic came from Harvard University and Stanford. Both publications were 2011. 60% of their hip replacements had the cup out of place in bad position. Both different institutions, both the highest level in the US, they have 60% of their cups malpositioned. In our practice, 0 for the past 7 years. The cup position causes most of the reoperations.
Okay. And ladies in Japan are very concerned about the look after surgery as compared to, for example, how many stitches as compared to the old way or conventional method as compared to how you're doing your computer-assisted surgery?
So for a normal-sized patient, The incision is about 7 centimeters, and there really is no visible stitch. Like this cloth, it's sewn together, but you can't see any stitches on the surface. The sutures, or the stitches here, are underneath the material. They're hidden. We use an absorbable stitch, and we sew under the skin, so you see a thin line, but no staples, no marks on the skin.
Wow, that's amazing. Yeah. So, Dr. Long, how soon after surgery, given your methods, are patients in general able to get up and walk again as compared to the old method?
Yes. So we call this minimally invasive surgery. Minimally invasive means, to most people, the small incision. The small incision also means under the skin we don't strip or tear a lot of tissue. We go in between the muscles to get to the joint. The second is the patient isn't inhaling a gas and they're not intubated. Third is we control pain with these nerve blocks. If we do that, we expect patients to be up, walking within 4 hours of the operation.
Wow, that's amazing.
80% of our patients will leave the hospital on a single point device, like a single crutch or a single cane. And it's the incision, it's the anesthesia, and it's the pain control.
Just a few years ago, patients are still complaining in some countries about the inability to immediately walk. In fact, they complain that they may be in the hospital for up to 2 weeks.
Yes.
Could you explain why this occurs or why this happens?
Yes. If you're not traumatized, if you don't have a big incision and you don't lose a lot of blood, if you don't hurt, then you can walk and you'll want to walk again. There's one more key. The most important thing that slows people down after hip replacement, the risk of ball coming out of socket. So they have precautions and say you can't sit up straight, you have to sit at an angle, you can't cross your legs. But if you use computer navigation, if you use a small incision, and if you put back in the ball size that you removed, patients can begin walking without any of those precautions. We had a 0.4% dislocation rate in the last 7 years. The national average in the US is about 5% of hips coming out of socket.
So you're saying you're less than 1%,
Yes.
but the average is
Almost
close to 5%.
Yes.
That's an amazing difference.
Yes.
Why isn't everyone running out to line up to take care of your,
Yes.
get taken care of by your
No, we think
expertise?
that computer navigation, just like everything else in our society, computer technology is changing the world in medicine. Surgeons have been slow to take on something new, and again, it used to take too much time and be too expensive. We changed the name of our practice to the Computer Surgery Institute because we think that within 4 years, and at least in the United States, it will be the standard of care and no one will consider doing that operation without that computer in the room. And in 4 years, no one will land that airplane without having that computer navigation on the screen of their 747.
Okay, and what do you recommend patients who, once they finish the surgery, how they get therapy or rehab those injuries? Are the methods used now much better than they were used in the past?
Well, there are two different therapies. Hip replacement therapy now, if the patient were to go home and the only thing they did is walk, they'd recover and they'd do very well with no therapy, most patients. Knee replacement is much different. You have to learn to get that leg straight and don't let it get stuck. You have to learn to bend it right after the operation where there's still a lot of swelling. So knee replacement patients need at least about a month of help with physical therapy, where many hip replacement patients can go and slowly resume their activities just after they heal, usually within 6 weeks.
Are there any things that you can tell our audience that you find that would be particularly beneficial to Asian clients who would receive your care as opposed to what's
Yes.
going on outside?
I believe that there's a special problem with Asian patients, especially smaller patients that are Asian. Number one of the reasons that they get arthritis, particularly in Japan, but other countries as well, hip dysplasia, where the hip isn't formed normally. A hip is too small and it's not formed properly. That can be corrected very well with navigation. Second, if a patient has a dislocation in most countries, nothing's done about it. They consider the operation a failure, and the patient has to live with a hip that comes in and out of socket. Patients that also have their hips put in other countries besides the US have limb length discrepancy, leg too long or leg too short. Very few places around the world correct these problems. We do it all the time routinely, so patients that have these problems need to look into coming to the US and getting them corrected with computer navigation.
Okay, thank you.
The question is follow-up. One of the beautiful things that technology is allowing us to do is to follow our patients and let them tell their story. So our website now has a site called Patient Video Library, where you get to hear from patients before the operation, hear their dreams, hear the problems they're having, and hear the things that they'd like to do. Then we show them walking side by side before and after the operation, and we show follow-up when they achieve their dreams or when they've recovered. So we want a library of hundreds of patients. Now we have about 10, but we have about 50 that we're working on.
Thank you very much, Dr. Long.
Thank
It
you.
was a pleasure hearing from you, and hopefully we'll be talking again. Thank you very much.